and then my first 20 patients were all going to come from TikTok, I would have had really serious inquiries about who I would become in the next 6 months. But here we are, so riding that wave, super weird. Yeah, I don't know if that anybody has questions or whatever for this whole thing. Like, I was just gonna, just talk and open it up to discussion and see what you guys are thinking. EDS is a real bitch of a deal, and it's a great thing to learn about. And I can't believe, like, another big surprise for me, I can't believe how many EDS cases and inquiries I've had for consultations with EDS people I've had thus far. And I think it's just because for some of my content on TikTok, I've done a little bit of education on EDS. I think I've done 3 videos on it, and like an outpouring, seriously, of people wanting help with it because they feel so, whether it's cast aside or neglected, underserved, like whatever you want to say, it's a really marginalized group of people. And it's actually, some of those papers suggested a much bigger group of people than we maybe think. And I think even the data push that aside, because I think it's even more people than what they can say empirically. So yeah, as you can tell, super scatterbrained all over the place. That's kind of how it'll be. I just bounce from one thought to another. I have no idea what I'm going to say next. So yeah, I don't know if you guys want to just start with takeaways, open up the discussion right away, and we can just sift through papers. I told Chris, like, I sent you all 3, but I think I have, what happens to my screen when I do that? Did I disappear? Or am I still on here? You see me?
You're still here. Let me let you share screen.
Oh, okay. I've got, like, what is it? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 10, 10, 10, I think. I think I have a few more than that. I got 10 on here right now that I think they all have different points that I kind of wanted to bounce around to. So if they come up organically, I'll hit them all. If they don't, then whatever. If anybody wants extra papers, I have extra. So yeah, we want to just start talking about it, whatever you guys are thinking, questions, or if you've worked with EDS people, your own experiences, let me know. So
Does
yeah.
anyone prior to reading these papers, did anyone not know what EDS was?
I didn't know what EDS was. I'm just in my second year of physical therapy school. And so we're finishing up pathology, neuro side, but I didn't come across this until today.
What about you, Aaron? Prior to having TikTokers, or I guess viewers of TikTok, come and talk about EDS, did they teach it in chiro school?
Yeah. Yeah, they actually kind of hammered it, like, surprisingly. As harsh as I am on chiro education, yeah, they really hammered it, because obviously, like, with the bulk of our interventions being centered around manipulation, they really wanted us to make sure that we didn't fuck that up. So I mean, because you're not going to go doing high velocity thrusts on somebody with super hypermobile joints. So they talked about that all the time. So I had a fair understanding of it. I wouldn't say I had somebody in my clinic rotation, man, my first rotation ever, actually, and they had EDS, and their only goal was to get back to activity. And I didn't feel competent enough at all to help that person. And my preceptor was just giving them chin retractions for whatever reason. Like, I don't know what we were doing. I don't even know if they had a neck complaint. I think they had a shoulder complaint. I don't know what that, it doesn't matter. And so that was like my first time I did kind of a deep dive on it. So I had looked into it quite a bit prior, but I've definitely upped that amount of looking into things now, just because, again, like, I was so overwhelmed with how many people with EDS were DMing and commenting and looking for help. So yeah, kind of dotted exposure all throughout. I don't know if anybody else has. If I would actually ask you guys, how confident do any of you feel managing somebody with EDS? Do you guys feel like you could do that and do it well?
So I had experience with Ehlers-Danlos syndrome working as a PT aide, and there was like a lot of these papers were that exact experience because I didn't understand it because I was just an aide, so I was just helping. And the patient would always talk about like literally everything that these articles talk about is like the learned helplessness and like all of these professionals telling them that it's in their head and because nobody understood it. So they just felt so misunderstood during the whole thing. But I will say it talks about in the, what is it, Rombau? I don't know how to say that last name, but like the 2011 paper about aquatic therapy. And so like using that as like a global strengthening exercise, we did aquatic therapy with the EDS patients. Like, I think, so it was like every Tuesday, Thursday morning, I did aquatic therapy with patients as a PT aide. We just go to the pool and do like strengthening exercises in the pool. And like that was the most freeing thing for them because it kind of eliminated the fear of doing things with gravity, is because like every time they were like sent somewhere and they would give them exercise or like mobilizations, it's like they were in so much pain because of it. So I do have experience with aquatic therapy. At the time, I didn't realize or I didn't understand it. I just knew that they were getting help from aquatic therapy. But the therapist kept calling it the zebra disease, as in like everyone's a horse and they're a zebra. So they're just kind of like hidden and nobody really understands it. So that's just my experience with the disease.
They call it that in front of the patient.
Yeah.
That sucks. And you know what's weird about that is actually Ehlers-Danlos, their kind of community like society page. I had it on here a second ago. Their logo is a zebra. That's kind of interesting. But anyway, yeah, so kind of to go back to that, and I had a ton of different papers looking at this and a lot of qualitative research too, but yeah, they have a really hard time, getting diagnosed. They have a really hard time finding somebody who's actually willing to take on the case. Like a lot of the ones that I've talked to already, and this is reflected in a lot of the papers too, they will be turned away by clinicians who don't feel competent enough to handle that. And they will be, obviously there's always the element of like being questioned on what they have. And I have, is sharing patient DMs HIPAA compliant? Does anybody know? Is this recorded? Nobody tell on me. I won't read it directly, but I did have a patient, two of them actually share that they were both diagnosed bipolar initially when presenting with EDS and prescribed antipsychotics, and they are not bipolar. So that's terrible. Yeah, it's really tough. And then I think I'll screen share. I can do that right now, can't I? Yeah.
Yeah.
I don't know why screen sharing gives me the most anxiety, because it's like, I know it's on my screen, but I also, it's just like, you know, I can't see you guys and I start freaking out. I don't remember what I wrote in my notes. All right, hold on. I'm figuring this out. Let's see. Desktop one. That sounds right. Open. Oh God, things are happening. Am I sharing my screen yet? Oh, there we go. Here we go. Allow.
Not sharing it.
Don't worry, it's gonna work, I think. Oh, now it's asking me to leave the meeting. Maybe I won't be able to do that. That's tricky. Hold on. Let me give it one more try. Otherwise, I'll just talk. Oh, this looks different. Share. You see it now?
Yep.
Let's go. I was really worried I wasn't gonna be able to do that. Okay. I'm gonna jump around like a crazy person, but we'll see how this works out. Can you still see my face too?
Yeah.
Wow. Technology is incredible. Okay. I just, last paper I read before this was a few days ago. And since we're kind of semi on the topic of some of the qualitative stuff, this one had a lot of really interesting considerations. So I want to start just going over some of the highlights I had on here. But if anybody else has anything to add before I do that, whether it's just questions on management or comments on their own experiences with people with EDS, any insecurities about whether or not you'd be able to take on a case like that, go ahead and throw out a question or comment on that. And then if nobody has anything, I'll just kind of start going through stuff.
I have two
How do you
things.
feel most insecure about your TikTok dance that you're promoting for Cairo? That's killing me. Can we see that? I know that's kind of pivoting and backing up, but I really need to see the TikTok dance that you're doing.
Yo, I've actually only physically danced on there. I think twice now.
I'm pretty sure you dance every time.
No, dude, I don't. You got to follow me. I just sit and talk into the camera.
I'm not getting
I've been on there for 2 months. Closing in on rapidly ascending towards 10,000 followers, by the way. People like evidence-based care. It's dope. I've been on there 2 months and I've posted, I think 70, 60, 70 something videos, like just hammering it. And I think I've danced 2 times. So if you're looking for dancing, I will disappoint you.
Oh, that's okay. In all seriousness, I think I've only seen one patient that had true like diagnosed EDS, and there's probably like some of the papers suggested, and you as well. There's probably more of folks out there that are dealing with this that we're just missing. But it was kind of challenging, and I still don't feel really great about it. It was like all she really wanted was a lot of manual therapy, like every modality under the sun. She just wanted needles and cups and massage, and was like pretty much unwilling to do anything else. Because in her mind, she used to be a gymnast and she knew how to be active, but like she had gone quite far away from that lifestyle and hadn't been physically active in a long time and hadn't really been doing anything. And she complains of shoulder instability, low back pain, neck pain, the body chart kind of filled out everywhere. But it was kind of like completely unwilling to try anything else other than just manual therapy. And so, and you could tell she was definitely frustrated too with the treatment she'd gotten. So there was a lot of like work and just validation, understanding, like, I understand where you're coming from. I know that this has been frustrating. I hear what you're saying, and mirroring a lot, of what she was telling us, just to make sure that we were clarifying like what she meant and what she didn't mean. But it still never got past very passive stuff. Like she ended up just leaving because we got to that point where it was like, well, you're not going to get that here. You know what I mean? Like there's got to be a next stage, and we can dabble in that, but there's got to be more anyways. And so, yeah, man, I don't know. I wouldn't say that I'm totally unconfident in treating it, but just based on that one experience I had, it didn't go super great. So,
Right.
I don't know where my false confidence comes from, but didn't go well the first time.
No, I definitely have a sense of that sort of naive, like, yeah, I can fucking do it kind of sense too. And probably that's just the new grad in me, but I would advocate for not losing that sense, because I think putting yourself in positions, I mean, within reason, putting yourself in positions to have those uncomfortable moments, that's going to provide that extra pressure to take that deeper dive and really try and establish a better understanding for yourself. So for me, a lot of my own biases were really challenged when I first started looking into what it's going to take to actually help somebody who's dealing with this or dealing with something similar. Because I mean, obviously you guys could probably tell from some of those papers, and if you clicked on any of the references, there's a ton of overlap between this and things like fibromyalgia and things like, chronic fatigue syndrome is really prevalent with people who are dealing with this as well, which is why I included that would probably seem like a totally random paper. Does anybody know how to say, I keep saying Nidges and I know that's wrong. Does anybody know how to say his last name? He's like one of my favorite researchers and I can't even pronounce it.
Maybe the J is silent.
Yeah, but then what would that sound like? Nidges? I have no idea. Knee, maybe. I honestly don't know.
I was gonna say, like, that's like based off what Q had said. I think you adding the chronic fatigue syndrome paper is really the underlying way to treat somebody with EDS. Like, if you can't explain it or they can't explain it, like learning how to deal with people with chronic pain is like one way to approach that with a disease that seems like nobody can really understand on best treatment practices.
Yep. Yeah, that was definitely part of my rationale there. There's some good points in that particular paper that I wanted people to look at was the concept of pacing with graded activity and graded exposure. So the way that some of my biases were challenged, obviously he touches there on manual therapy in this case. So I mentioned that I'm going to be primarily digital for a lot of my work, at least until I open up my physical clinic in just a couple weeks. But in a case like this, I feel like my lenience on manual therapy and my willingness to provide something like that and a lot of the other passive modalities. And like, let me be clear, like I'm a jerk about like passive care. Like I poo-poo that shit so often, but I would definitely pivot that in this kind of scenario, just because, within reason too, like obviously the narrative has to be on point, the patient has to have a good understanding, but I think, and Chad Cook talks about this a good bit is like the way you can leverage that to sort of build a level of partnership and establish a level of trust. If that is your intent, I really think that that's a valid reason for doing some of those things, especially when we take into consideration the level of distrust that a lot of these people tend to express towards anybody in healthcare because of a lot of the difficult experiences they've had trying to get help and not having a lot of good fortune there. So if it's a rapport thing, like my mind opens up a lot more. And then with the graded activity stuff like that, if I had to summarize like what it is I actually do, and this is like the biggest struggle I have marketing for myself on a place like TikTok, is like people ask me all the time, like, what the hell do you actually do? Because you rip on adjusting and you rip on manual therapy and you rip on corrective exercise and you rip on this and you have nothing good to say about anything. And like, what do you actually do? Do you just talk to people? And I was like, I mean, kind of like it's a computer screen. That's all I can do. But no, I really do just do a lot of education and then graded either activity or exposure type stuff and then CBT. But that bias gets challenged a little bit here too, because if you look at a lot of the work on people dealing with this, exercise pretty much equals bad for them. Like it almost always makes it worse. Even if it's done in a very gradual summation type layout, it still makes it worse, which is not exactly par for the course with most of the people and cases that we deal with. So that's where I think this gets really tricky. And we have to look at some other key pillars of that therapeutic alliance and just principles of good rehab that we're going to have to rely on more dealing with these people than we would with the typical case. So like my bias is towards, I'd say education is still just as important as it ever was, maybe more so now for these types of cases, but the graded activity bias sort of gets poked at a little bit. So yeah, I don't know if that brought up any thoughts or questions for anybody, but if it did or did not, I'm just going to start scrolling here. So yeah, I was going to say just start talking.
Yeah, I have a question.
Yeah.
With you had mentioned in which paper was it? I think it was the chronic fatigue syndrome paper, the concept of pacing, which to me just sounds like what you're talking about with graded exposure.
Yep.
Because you're all telehealth or 90% telehealth, what is actually changing for you?
Yeah. Okay. That's a good question. So, and I've had the opportunity to implement a little bit already, just because I've gotten started. So the way I'm doing telehealth cases right now, obviously, creating a practice is pretty time consuming. So I'm only taking on a small caseload, and I've had to tell the majority of the people who are messaging me that we have to wait until February. But for the few that I have started with, I have started implementing this. What it ends up looking like, I would say, is a lot more. If anybody was on that call with me and Jake, he talks about all the time that um, we shouldn't put the responsibility on ourselves to try and predict pain and predict how people are going to respond to different things, even if you feel like you do have great pattern recognition and like you're going to give them something and think to yourself, yeah, like I know how this is going to play out. You shouldn't make that type of assumption, and that becomes really exponentially more important here because of just the crazy amount of variability and the real lack of any sort of pattern with pain. So with a typical patient who I'm giving graded type stuff to, like it is just a common sense approach, find the baseline, find what they can tolerate, establish those tolerances, and then just start gradually building. But the open line of communication, asking questions like, do you think that this is going to be something that you can work with? Is this too much of a step for you when we're talking about like progressing, right? Is this too much of a next step? Are there other ways that you would want to progress? Like a good example of that is I just had a patient yesterday who we were just gradually working our way up, and she mentioned that the weights themselves, she felt fine moving them, but um, the actual size of the dumbbells, not the weight, but just the way they looked in her hands when she was watching herself work, that gave her a lot of anxiety. So the thought of continuing to progress just linearly with the weight and the load was really starting to make her uneasy because just she was so unused to seeing herself like in a mirror carrying such large weights, right? So she voiced to me that she would like to do the next set of progressions by some other means, whether that meant, tweaking biomechanics to put a little bit more tension on certain areas or playing with tempo, playing with reps, that kind of thing. So that's just an example, but that type of shared kind of decision-making communication, I think is the biggest key. And then when we consider it with pacing, it all becomes really time contingent. So I think a lot more conversations than I would typically be having with patients is going to be a theme with people with EDS, because I tend to really space out how many touch points I have with people. I want to give them the chance to go off and figure things out on their own and not have me there so much. With EDS, I think it's going to be a little bit less so because you're going to have to take the time to get an understanding of how they feel about, what's going to be too much, how much rest do you need before you can try something else, how much does your capacity and your level of fatigue fluctuate on a day-to-day basis, who relies on you in the house, what are your responsibilities, how does this impact your occupation, all of those considerations. So it is still graded activity. It's just the focus just shifts a lot more to way more communication than a typical case. And like, obviously communication is always super, super important, but like it gets that much more important here because there's just so many more relevant variables that go into what dictates their level of disability and their level of suffering. That was a super all over the place way of addressing that, but that's kind of how it goes.
What does your means of communication look like? Like those touch points that you referred to, like how do you approach that? Like, is it a questionnaire? Because a lot of times people don't know what to say and like to figure those things out? Like you had mentioned, like her or their idea of holding like a weight scared them. Like how did you probe for that? Like did it just come out naturally, like they were concerned about it? Or is there like things that you've implemented to initiate that conversation?
Yeah. I don't know, and it's hard for me to even really say this confidently, just because like I can't really compare my own approach and my own communication style to other people's. I don't know how anybody else does it. But a big part of the reason that I went into practice for myself, and I'm not working with anybody, it's just me, is because I like the way I communicate with people. I like that it's nonchalant and not terribly professional, and that it is just two people. Like I'm not even like, I don't even look at myself like I'm a healthcare provider. I'm just a guy who knows stuff about pain and exercise, and I'm helping them. So that level of communication, at least in my own experience, seems to open up the floor a lot more and make people a lot more willing to volunteer certain things to me. So it doesn't really take a certain level of probing to get that information out. In that exact example, all I said was like, is anything, making you feel a little bit uneasy? We've come a pretty long way from where you were. You're doing quite a bit more. Like, how are you feeling about that? And just being like, it's like typical motivational interviewing stuff, super open-ended questions, and then just shutting up and giving them the floor to voice whatever concerns they have. But yeah, I don't know. It's not super structured. And I'm not like thinking to myself beforehand, I need to find this out. It's just kind of whatever they volunteer. But I think that really open line of communication is really conducive to that, I would say. And then how open the line actually is for communication, that gets tough because that depends on what, I hate calling it a package of care, but like that's how it is. Like I offer my services in kind of tiers, and the tiers are solely based on my level of involvement with care. So if somebody goes top tier, that has a lot of involvement from me. So they're going to be talking to me face to face on video call a lot more frequently, which is also obviously a factor just because of how often we communicate. So yeah. I'm gonna look at this paper that I was looking at a second ago because there's some sick highlights in here, and I think they give a lot of interesting perspectives on things. So I don't remember where each one was. I'm just gonna glance at it, and whichever one catches my eye that I remembered I wanted to say to you guys, I'm gonna bring up. But this one, okay. So this is a qualitative paper, obviously. They got some good perspective from some of the patients. There's a lot of, I noticed as I was going through this last week, there's a lot of instances where some of our like really common means of communication can be misconstrued. And I think this paper highlighted a few of those. So I wanted to point out right here. Yeah. Okay. Poorly understood conditions. So the perception by the patient that the clinician doesn't know what the F they're talking about and probably doesn't have a good understanding of what's happening. Participants perceive the JS to be, so I'm extrapolating this to just joint hypermobility syndrome, but you guys can see obviously not going to be a hell of a lot of a difference, and you can apply this to EDS. This quote though, I think I was described as a biomechanical conundrum by one of the physiotherapists I saw, and this is what I found repeated over and over again, that hypermobility shouldn't be causing pain. It's just the way you are. So the reason I highlighted that one early on, when I first started really looking into EDS, I was really attracted to the idea of trying to leverage just a very basic understanding of pain science to maybe reassure the person that their pain can change. And what I specifically mean in that example is, I think there's a belief that because they're so hypermobile, that it is inherently damaging to the joints, and that it is like with all that extra range of motion that it's going to damage cartilage and harm capsules, all that kind of stuff. And so with that assumption of patients looking at it that way and the recurrent experience of subluxes, my idea initially was to leverage that and say, well, there is a disconnect between how mobile or how immobile you are and the actual experience of pain. Like just trying to pull, sensitivity from structure, right? A basic communication point for a lot of people. But you can see from that line that I just read how that could be misconstrued by a patient. Like you're calling them some kind of biomechanical anomaly. And you're almost saying like, it shouldn't be this way. It is for you. And that's weird. And it shouldn't be like that because you're explaining it as if there should be this disconnect. And like, hopefully that makes some level of sense. Because like, how often do we want to talk about, structure's not your destiny and yada, yada, yada. I think if we're not really clear about how we're saying those things, there can obviously be some tough takeaways, and we always have to be cognizant of the fact that this is a marginalized group of people who are coming into the interaction with the expectation that you don't fucking know what you're talking about and that you don't understand them, right? So like we have to take that into consideration. A few more.
I think that a lot of times, no matter what the condition is, it's hard to walk around on eggshells about things that you say, and
Yep.
you don't really know how a patient is perceiving what you said.
Yep.
Or like they've just heard the same message so many times that you could say something and they're like, oh, another person that doesn't believe me. So is there a way that you approach people in pain and ask them at the end, like, okay, like what did you understand from our meeting? Like, how did you perceive it? And then you can kind of like combat those like stressors that they have with things that you say, because maybe that person had the intent of saying like, you're hypermobile and you've been told all these things about that. And like, even you saying some things that you kind of believe at that instance, maybe you don't know exactly, but like, just, is there a way that you word that question at the end? Like, what did this conversation look like for you?
Yeah.
Like when you're
So,
asking.
again, for me, I really think it goes back to my communication style and the different type of relationship that I build with patients, that it's not necessarily a doctor-patient relationship, but more of like a person who knows some stuff about what you're dealing with, and then you're the person who's dealing with it, more level playing field. If I say something that creates a mismatch, and again, like that, you can't really take this for anything because I have so little experience. I've only had, just above double digits of clients, and I haven't been at this long, but the way that I set up those relationships, at least in my experience, people have been a lot more willing to volunteer stuff, including disagreements. And like they're not gonna be passive aggressive about it and come away from the conversation having not said to me that they don't agree with what I said, or that they didn't understand, or that they feel like they'll accuse me of like not understanding what they're going through. Like they'll let me know. And I've had that happen. And like the key with that is just to be super humble and take that as a good thing, because it's another opportunity to be a little bit more clear and show the patient that like you're open to that sort of criticism and that sort of mismatch, so that you guys can clear the air. The most recent example that I can think of that is I'm working with a woman who diagnosed fibromyalgia. I recommended to her that she go see her rheumatologist to get checked for rheumatoid factor and all that stuff again, just because of, how crazy long it takes to get an actual diagnosis on some of those things, and how frequently we can have tests that say we're negative when in fact it's still actually an issue. So, but she pointed out to me that I was giving an explanation to her that it's hard to explain because there's like a lot of nuance to why I did this. But basically, I gave this woman a Turkish getup. And I say that very tentatively because I don't believe in giving silly exercise prescription, and that kind of shit drives me crazy. So you're probably thinking like, why the hell would you give a person a Turkish getup? Like, how does that apply to anybody? So just quickly, rationale behind it was she's somebody who doesn't take value in exercise unless she feels like she really, really pushed herself. So Turkish getup, obviously, you can do 3 reps and feel like shit. So that works there. Check that box. She also mentioned that she's put the limitation on herself that she shouldn't be using more than 5-pound dumbbells. And with a getup, we're starting body weight, and I think I can work her up to 5-pound dumbbells quickly. And the whole rationale behind that is, okay, I'm hoping she comes away with the realization that, wow, I can do this ridiculously complicated movement with just a 5-pound weight. I can probably do some other stuff with just a 5-pound weight and probably more weight than that, right? So just kind of reinforcing like, hey, you can handle more than 5 pounds. And then the last one being the actual reason I gave the getup. When she turns her neck, very consistently runs into sensitivity, like at a certain point in her range of motion when she turns to the right, like all the time. And she's very aware of that. And so what I was trying to do with the getup was create this mismatch that maybe it's not a structural thing that she's always running into, and that it's always a pinch or something getting stuck, by putting her in a situation where she can glide through that range of motion and not hit that point. So what I did was halfway through the getup, when your arm's in the air and this one's down, I don't know how to say it, but I have her basically just floss back and forth between both thumbs and look at each one, working full range of motion. And the idea being that, she's under so much tension at that point. She's so focused on the nuance of the exercise, and her body plane has changed quite dramatically, hoping that she realized, wow, holy shit, I can go through this full range of motion. My neck's not pinching. And she's doing all of this other stuff. So like just distraction, type shit, right? So trying to create that mismatch. Those are the only reasons I gave a getup. And with that, she was super frustrated when I started telling her about adding in that neck piece, because she was like, well, what the hell? Like, you're giving me this super complicated exercise. It's gonna be really hard. And then you're gonna make me like tap in and poke into that pain right in the middle of it. Like, how is that gonna work? So called me on it, which I appreciated, because if she hadn't, she probably wasn't going to do those like for 3 weeks, until we talked again. So that gave me the chance to kind of reconcile that, which again just comes from the type of relationship you set up with the person. I think it is a good idea to give them the opportunity to call you on stuff and level the playing field. But yeah, I don't know if you guys are noticing a pattern that my answers all take a really long time. I'm going to keep scrolling here. Right. I think there was one. Yep. Here. So another kind of challenging own biases. We all know how we feel about like non-specific versus specific diagnosis, and kind of the discontent with, if somebody is dealing with a non-specific pain situation, not being able to point at a structure or any named condition and just telling the person, okay, well, I can tell you what it's not, and hoping that that's sufficient. This is another one of those examples, like reinforcing the idea that patients do want a diagnosis, because here you're seeing, getting a diagnosis on paper, this is what's wrong with me. I mean, that helped huge psychologically. So like validating for that person, yeah, you have Ehlers-Danlos syndrome. This is why you're dealing with that. So, it has a place. Like, does that mean that I'm going to go tell the next non-specific back pain case I see that it's their freaking QL? Obviously not, but it can really be a big pain mitigator for people to be validated and get the label. you know. But then with that label, this is something I was talking to Jake quite a bit about. With that label, like what does that add to the situation? Because now, however much they identify with it, like they're now a person with a connective tissue disorder that's known to be quite challenging. So yeah, you've been validated, but how much of that do you really embody now? And I know there was one thing I highlighted. It might have been in one of the papers I actually sent you guys and not one of these other ones. Did you guys have one of the papers look at the SIP outcome for sickness index, I think it was? Do you guys know?
That was the 2011 brown bat one.
Yeah. I'm trying to find that because if you noticed there, alertness behavior,
Yeah.
that stood out a little bit more. And I was looking at all kind of the other things that I thought the other stuff would be a little bit more prevalent than alertness behavior. And I didn't really have a good understanding of what that is. So I looked into it and it's like this, I'm going to butcher the explanation, but it's like this disconnect with being like always feeling like people like talking to them and it just seems like they're somewhere else, you know, spacing out, not being able to lock in and focus on stuff, right? That kind of deal. And I read that and then understood kind of how some of the qualitative stuff reflected how hypervigilant they can become with what they're dealing with and with the frequent subluxations. And it made me kind of wonder like how much of that contributes to that whole alertness behavior. Is it because they're so frequently in everything they're doing thinking about the fact that they have this connective tissue disorder that basically makes it so their joints can just pop out like when they're walking down the street, right? So something to consider. I don't know if that's something that can be leveraged in patient education or if that's something that can just help guide some of the questions we ask. And when we're trying to get a better understanding of their experience, but it's definitely not for nothing. And again, like it's reflected in a lot of these papers, how much consideration their condition gets with planning and day-to-day life and relationships and all of that stuff. So, yeah. Just one more thing that I kind of was thinking about. I think there were just a couple more highlights on this paper that I wanted to make sure I brought up.
Of the
Oh yeah, this is awesome. Yep, go ahead. Sorry.
clients that you have with EDS, do you know how many of them are on antidepressants?
Two of them were. Yeah. And all of them are unemployed, which is another point that I was going to hit. Obviously, that's a massive consideration. But yeah, only 2 on antidepressants. I'll come back to the unemployed thing.
Aaron, are they all female or do you have any males?
Nope, all female.
Is there a reasoning behind that?
Yeah, more prevalent, obviously, with females.
Why is it more prevalent? Have you read on that?
Why that would be, I don't think they have a good understanding of that. And I think you guys probably got the sense too when you're reading through stuff. There's still a ton that's not well understood about Ehlers-Danlos. Why the mismatch between male and female, I don't know. I couldn't help but wonder too, like, while I was thinking that I think it's actually more prevalent and I think it's underdiagnosed, I also think there's a good possibility that people who don't have Ehlers-Danlos syndrome get slapped with that tag too, just because they're really bendy. I think that's entirely possible.
Is it Baton scale?
Criteria? Yeah.
Yeah. So do you run through that with your clients that have it?
Nope, just because, you know, they're coming to me with the diagnosis. And obviously knowing that they've all probably had their run-ins with medicine, with healthcare, like I'm not going to challenge that. I'm not going to be like, oh, well, maybe you don't have Ehlers-Danlos syndrome. So no, I haven't run through that with them. But if you look at it, like, I mean, shit, I mean, the first time I read it, I was like, okay, well, I can think of like a million girls in like back when I was in like elementary school, middle school, who could do all those things, you know? And it makes you like, did they all have Ehlers-Danlos syndrome? Probably not. Probably just really stretchy. And then also we know that like the hypermobility subtype is the only one that's not getting a genetic confirmation with
So
testing.
is that how they confirm the diagnosis is like a genetic confirmation? Obviously, like a bunch of clinical things, but like how are they diagnosing?
Yeah,
EDS?
so that's part of what's hard too. With the hypermobility one, the one that is considered to be the most frequent, from my understanding, it's all just clinical criteria and then family history. That's the only one that they're not getting a genetic confirmation. So again, that's what makes this fucking hard, is like, is it overdiagnosed? Is it underdiagnosed? Where are we at? Obviously, it's not my place to say, because I'm just the chiropractor on the computer screen who's trying to help them get whatever they want. So it's like, they come to me with it. I'm not, if I had a suspicion, I would refer out. I wouldn't take somebody through the criteria probably. But yeah, that's a good question. This point right here, I'm still sharing my screen, right? Okay. This point right here, the fact that so it's talking about self-management. This quote, I suppose it's where someone who doesn't really know about it, they've got to learn about it first, because you can't tell someone to do it if they don't understand it. So they're talking about how they would like to be educated on what they're dealing with, but then they also make points about how they want to know that their clinician is more educated on this topic than the average person, just because of the stigma of how little is known and maybe how many times they've been turned away, or people have expressed a lack of competence with dealing with this. So what I have done, in all of my cases except for one, and there's reasoning for it, I've shared papers with patients. It's not always papers, because I can get a sense of like who would want to read like highlighted quotes that I sent them. I'm not just saying, here, take this paper and read it. I highlight shit for them, say, hey, I wanted you to look at a few points. Tell me if this resonates with you. Tell me if this, gives you any sort of reaction or not. Because you can get a sense of like who would actually value that or not. So for the ones who I thought would, I've shared with them papers. And all of them every time have been super excited about it. Excited that their clinician is reading research, which I think we don't give ourselves enough credit, that like this is not the norm to be doing this level of extra work. I know in our echo chambers it can feel that way, that like everybody's doing this and everybody's reading a ton, discussing a ton, and taking time out of their Saturday to talk about Ehlers-Danlos syndrome, but they're not. So letting your patient know that you are doing extra work, especially if they have something like this, can go a long way. And then, they appreciate the education piece. They get that extra dose of confidence knowing that I'm doing my due diligence and I'm still trying to learn. And then this last point here was super cool. This two-way process with learning. So you see that. So I think I got a huge amount of enlightenment from her, and I lend her books and she lends me books about hypermobility, and all that helps. So I've done this with 4 of my clients, where I just said to them, hey, I feel like I do know more about this than the typical musculoskeletal therapist, but I'm still learning. And for teaching purposes for students, I still want to keep sharpening my understanding. So I've actually asked 3 of my patients to jump on calls with me and straight up just tell me stuff that they would want every clinician to know about their experience. And that whole perception of them like teaching me, and I'm taking a step out of the educator role, and now I'm the student and they're telling me so much, is super empowering for them. And then also gives them that sense of like, wow, this guy really is listening to me and is making a lot of effort to learn about what I'm dealing with. So,
What type of things would they say? And then second question, when you send them papers, are you trying to guide them of like, you'll highlight certain sections of it, or are you just like, here's some articles, I hope you enjoy it? Like, how much do you provide?
yeah.
Yeah.
What I've done is I've purely based it on like, I haven't said it as like, hey, I read this and I want you to read this and know this. Like, I think this is important for you to know. It's always just been like, hey, I read this and it made me think of you, like based on things that they've already told me. And I said, hey, I read this. It made me think of you. I just wanted to see what your reaction would be reading it, because I felt like, you would have something to take away. So just really open-ended and saying, hey, like, again, showing them that beyond the visit, they still exist in your head outside of when you're just speaking with them.
Are you always sending positive papers? Because a lot of the papers,
No.
at least the ones no, you're not.
No. Nope. And I'm really careful about that too, because there are things in some of these papers that I wouldn't want them to read necessarily. Not that it would be the end of the world. And I do think like setting realistic expectations is 100% crucial, but there are things that you can read in these papers, obviously, that would be discouraging too. So I'm really careful about that. But no, they're not all positive. Like I've some of the qualitative stuff I've sent have been about like some of the horror stories of doctor visits. Like I remember one that I shared with a patient because she told me that she had a similar experience, was essentially the fucking doctor came in with a student and said audibly, all right, show them your circus tricks. And then had the patient, contort their body whatever they could do, like, like in front of the student and in front of the doctor. So that's fucked up. And a patient had told me that had happened to them. So I was like, hey, like I've been reading up more. You're definitely not alone with what you went through. And we as healthcare providers have a really long way to go. And just by saying like, you're not alone, that didn't just happen to you. I'm trying to get a better understanding of it and I'm imparting it on other people. I think that is beneficial, just again, for the whole relationship, because I think the relationship is 100% the most important part, especially when you're dealing with something this complicated. Yeah. But no, I'll go negative. I know I seem sunshine and rainbows all the time, but I'll go negative. I'm not afraid. Here they mentioned pacing. So crossover with that concept from Joe's paper on chronic fatigue syndrome. Participants also recognize that activity pacing is really key. It's like a balancing act. If I do too much, it all hurts. If I don't do enough, it all hurts. Do it just right, I'm okay. That trend, though, is not consistent at all, at least not from what I've been seeing in a lot of these papers. It basically, people, it seems like it can be really variable and unpredictable, the behavior of their symptoms. So like we shouldn't really, again, like put it on ourselves to look for a pattern. We should, and this is kind of a good opportunity to touch on like actual practical approach to prescribing exercise. I always do progressions and regressions, just like me and Jake talked about on that one call. And they're simple and they're easy to implement and scale. And the reason that that's extra important here is because if you've given a patient a wide map of progressions and regressions that will still be conducive to the goal, if they're having a shit day and their symptoms are just not like, I mean, it's just all over the place and we don't know how they're going to react to things. If they're here on the scale of progressions and regressions, but they have a clear roadmap and they know how how to regress the exercise so it can come all the way back over to here so that they can still feel like they're doing something that's still conducive to the goal. I think that's a huge win, because one of the things that these people express a lot is that there's a level of like blame and self-loathing that comes with failing to do the things that are valuable to them and ending up in that bedridden, debilitated state. So if you can give them that level of plasticity with their exercise prescription so that you can really scale it to basically anticipate almost any kind of scenario with their symptoms, you give them a good opportunity to not have to feel that way and to not have to sit and say, I guess I just can't do my stuff today, you know?
What are your thoughts on, well, one, have you heard of the patients with the EDS? Do they have like groups that a lot of them are part of that they can communicate with and share experiences? Like, do they naturally do that? Or two, would you ever think about introducing individual, I don't know if that's HIPAA reliant, but like, what are your thoughts on introducing them to people who have similar things? Because I could see it going both ways of like, one, it creates community and maybe sense of help, but also, as you said earlier, like then do you start to identify or kind of make that all of what y'all talk about, and does that just make it worse?
Yep. So I've done that already. I've recommended all but one to that Ehlers-Danlos Society to enroll themselves in that and become part of that community. I've sent that to every single patient I have except for one. And there's reasoning behind that. Another consideration I have had, at least for the future, is okay, this is a little tangential, as I'm sure you anticipated most of the things I'd say would be, but so for my physical practice, one of the things that's really appealing to me is, well, I should back up. I don't like that I had to go with a cash model, because although I think it's the only way that I can practice my approach and not end up homeless, it does limit who can access me pretty dramatically, which is something that I have to reconcile with and just accept. It sucks, but it's the way it is, at least for now. But I think all the time about like what I can do to change that and open up that net as far as like who can actually get access to me. And one of the things I think about all the time is really much more affordable group exercise. And then subgrouping patients who are dealing with similar complaints, who could come in at the same time and work together with like just basic group rehab. And with EDS, I think that would be awesome to do, and just have them all come in for a session at the same time, and I'm with them and we're all taking them through the same kind of stuff. Because obviously, like, you know, we all make fun of CrossFit from time to time, but one of the things I love about CrossFit is that social component, that sense of community. And I think that's what people who are in those communities love the most about it. So if we can leverage that in rehab and give that to people, especially more marginalized people like this, that's a really cool opportunity too. So yeah, to put the cap on that question, I always recommend Ehlers-Danlos Society to them and hope that they'll do it, except for that one person. And then I'm always kind of thinking about what other ways that I can form a sense of community in a rehab setting, at least like more intimately under my own umbrella of my practice. Yeah, I think it's a good approach to take. That answer that? Chris, you should go into radio. Has anybody ever told you that? You have a great speaking voice.
It's the best thing you could have ever said to me. Thanks, man.
You know what, though? It's not, because I made that comment on your Instagram about pickleball, and you said that was the best thing I could have said to you. So which is it, buddy? Make up your mind.
Also, radio is a dying art, so maybe it's not a compliment. Maybe you're just
Put
trying
a charge back into it. You're what they need. I'm just saying, it's got that smooth, like as you were asking me that question, like I was having a hard time listening. It's like, wow, this guy just speaks so well. It's incredible. I think there's a few touch points, other ones I wanted to hit on. Does anybody else have any questions or comments? As we're
Oh, Quinn, you got it.
Yeah, no, I was just,
Yeah, go.
I guess, something that I keep kicking around in my head is that a lot of the themes of this conversation really aren't too far removed from maybe the other stuff like low back pain. I mean, even
Yeah.
shoulder, right?
How
I mean,
about that?
what was that?
No, yeah. How about that, right? It's all those principles always seem to stick around. I love it.
Yeah, so I mean that level of diagnostic uncertainty, I mean, we look at the shoulder and all the work from like Jeremy Lewis's crew. It's like, hey, you know what? Doesn't matter, man. People are gonna have shoulder pain in all kinds of places in the shoulder, and based on MRI, there's no real way to tell where exactly that pain is coming from, and abnormalities exist in everybody. So, do the best you can with the presentation. Same with low back pain. Same with like hip pain stuff. I guess these are very common recurring themes, and I guess letting your patient in on some of that, like, hey, there is a level of diagnostic uncertainty. We don't know everything about this, and maybe people get extra frustrated with Ehlers-Danlos because it's not something that typically regresses to the mean of getting better on its own. It's something that is going to persist because there is some kind of congenital component here. But I guess I'm wondering in my head, and the question I keep asking myself is, so what is the real difference then in the conversations we're having with people with EDS versus something else? Because in my head, I'm like, well, man, I would have the same conversations with other MSK folks, and it would all be scalable activity. It would all be like, think about OA, right? I mean, that is completely symptom driven.
Yep.
You know what I mean? It's, oh, on this day, things were flared up and swollen. So, okay, here's how I scale this. Here's how I regress, progress, lateralize, you name it. And it's the same thing. You're going to be dealing with this for the long time. I'm not going to change your OA significantly, but we can change your tolerance to it. We can change your function in things that are not aggravating, and perhaps get a little bit stronger or a little bit better in some things that maybe you're missing out on.
Right.
I don't think this doesn't have to be debilitating. You know what I'm saying? So maybe you can talk a little bit about that, like how incredibly different is this in the conversations you're having than another type MSK?
Yeah. Well, it's good to point out because obviously I think once you have, there's a really good blog I read. I was feeling particularly dead inside one day, and a good friend of mine sent it to me. It said, it's from Eric Mera. It's titled "Simple is Hard," and it talks about how having an incredible depth of understanding in a subject will ultimately end up making things on the surface level to somebody who doesn't have that depth of understanding seem really straightforward. And I think in these communities, like clinical athlete, people do have that depth, and you start to recognize like how the principles spill over into every single case and what applies to everybody, and when things get more nuanced. So like, I totally agree with you. I think a lot of our conversation points will be similar. Some of the key caveats I would change, setting expectations up front, right? That's the most important thing to me, and has been with every EDS patient that I've spoken with, is figuring out what they want from me exactly and what they think is about to happen before I go and set the expectation. Because some of that stuff doesn't need to be said if they come into it already understanding it. I've been fortunate that every Ehlers-Danlos patient that's reached out to me, and this is a product of marketing too, I should say. So this is a good for anybody who is going to go and work for themselves or start their own practice. I market myself and make it clear that what I do for people a lot of the time is help them just get back to whatever it was they want to be able to do, and act as a guide in doing so. And by setting myself up that way and having that be a consistent message with a lot of my educational posts, people who want that are the ones who seek me out. So I've been very fortunate in the fact with these Ehlers-Danlos cases that every single one, their goal, or part of their goal, I should say, there's obviously other more nuanced pieces to each one, but a big part of every single one of their goals has been, I want to get to a point of being able to do some level of regular exercise. And the common theme is that for whatever reason, they don't feel like they can do that without me guiding them. So having said that, that makes it a lot easier on me as far as expectation setting, because they're not coming to me and saying, I would like to be out of pain. You know, they're not expecting that from me. And again, that's a product of some of the marketing I've done. But if somebody didn't come in with that understanding, I mean, I'm not going to promise that we're taking pain away. I'm not going to promise they're never going to sublux again. I'm not going to promise that I'm even going to change their hypermobility, because this is a connective tissue disorder that, I mean, we can strengthen the shit out of them. They're probably still going to have some issues at that end range. So the things that I will feel okay telling them that I think we can get done is find ways to try and get them back to work, find ways to help their social circumstances a little bit. And with that regard, I mean by planning a little bit more, and maybe setting things up for them to make that regular activity a little bit more feasible. So a good example of that I often give is like how do you set yourself up for the win? If you want to have a productive morning, maybe you're somebody who makes the coffee or gets it all set up for you to just make it quickly the night before, and you make it easier for yourself to get those goals accomplished and check off your checklist. We do the same thing with rehab. So I say, okay, like how can we just optimize your social circumstances to make sure that we're giving ourselves a better chance to hit goals and do what it is we want to do? So, if it's going for a walk for an Ehlers-Danlos patient, we're going to figure out the best route for them that's going to have the least amount of things that's going to make them feel like they're going to trip and fall or sublux or feel uneasy or apprehensive. Whatever is going to be the most scenic, most enjoyable. Like I take all of that stuff into consideration. And sometimes maybe it can come across as a little over the top, but it's all, to me, just setting them up for as many wins as they can get. Yeah, I don't know how I got there from your question. That's crazy. My brain is nuts. No, there's a good point in here that I wanted to touch on though, that you just made me think of. But back to your thing, setting expectations, communication points. We're not going to take your pain away. We're not going to take your hypermobility away. We want to get you back to doing what it is you want to do. And in doing so, just try and make life around the condition easier. Because again, like broad strokes, like what is our job really? I think is always a good question to ask for students, because I think you should be able to say it in a sentence. And for me, it always is taking a person with a level of concern or distress or pain and getting them to a point of active coping. I do believe all pain can change, and I do believe all people have the there's always a possibility of becoming a person who is pain-free. Doesn't mean that I always promise that, but because I understand that it's really hard to change pain in some instances, I just go with that adaptive coping model and at least find a way to get them to live with what it is they're dealing with. So with that always kind of in mind, that gears a lot of my communication as far as setting expectations and then managing their goals too with what they want. There was some really good shit in here about what determines. I should have sent you guys this paper, honestly, because when I read it, I was like low-key mad at myself. I was like, oh, damn, this would have been way cooler for them to read. They talk about in here what determines a lot of their behaviors and what goes into their decision-making. And I think this is a really good piece to read. If I'm on the right paper, I don't even know. We'll find out in a second. But people who know about fear avoidance and catastrophizing, I think we make a lot of mistakes with having too surface level of an understanding of that behavioral model. And I think we make the mistake of assuming that all avoidance is driven by fear and pain-related fear. But there's a lot of things that can make somebody avoid something, and it's not all mediated by fear. I think the worst example of this I have literally ever seen in my entire life of this misunderstanding was in my clinical rotation. I used to challenge my preceptor a lot and like try and show him what I was learning, and always being like disagreeable and just, always having something to say about everything. And I was talking to him a lot about like behavioral type stuff and Linton and Valayan's stuff on fear avoidance. And he liked what I was telling him, and he liked the idea of incorporating that into what we do when we're helping out people who are dealing with persistent pain. But he totally butchered it in the sense that he would literally like say to patients, well, what we're seeing from you is a level of fear avoidance with this. And you're starting to kind of catastrophize it a bit too. And I was like, I want not to have told you about those concepts. So that, I mean, like that's an extreme example of what can happen with a really surface level of understanding of some of these behavioral ideas, but this paper touches on it really well. So I'll kind of go through some of the highlights with this. There's some good highlights on prevalence too, saying the same stuff we've said, probably underdiagnosed, also possibly overdiagnosed. I have no idea. Yep, consistent reporting that physiotherapy makes them worse, exercise makes them worse, it doesn't help, makes fatigue worse. We haven't talked about fatigue much too. Should have probably said more about that. Okay, barriers to exercise. So here they say fear and injury, right? Fatigue, pain. But that fear and injury right there, or fear of injury, you notice that that is the smallest of those three barriers that they mentioned. That's the least prevalent one. And I think like if you're somebody who just read your first fear avoidance paper and then you learned about Ehlers-Danlos syndrome, you might run into the mistake of thinking, well, these people are all going to be petrified at the idea that their joints are going to subluxate and that's why they don't want to exercise. But I think you'd be really mistaken in making that assumption about an Ehlers-Danlos patient. It's probably a factor, but is that their only motivator? Probably not. And they go into how they make decisions here. They talk about more of a cost to benefit ratio and how depending on what the activity is, that can sort of supersede and trump some of the other concerns that they have. So what for me that really puts a big highlight of importance on is, again, really getting to know each person and trying to figure out some of their values and what's important to them. Because like you could have somebody who exercises the most important thing in the world, but then what you might run into is because of the fact that for some of these people, the thing of highest importance to them will often trump pain and get them to do that thing in spite of their pain. That would be a recipe for probably a really rare instance of like a boom and bust type relationship with exercise for somebody who's dealing with EDS. And if you run into that kind of pattern, how much harder is it going to be for them to do the things that they need to do in daily life that aren't as important to them as exercise? So then you run into this pattern of like, oh my God, they smoke themselves with exercise because that's more important to them than anything. But because of that, they're in incredible pain. Now it's impacting their job and their social life. Now they're pulling themselves out of social circumstances. Home life's getting difficult. You see what I'm saying? So like understanding that it's more than fear that dictates their decisions, and just getting to know a person really well is going to give you some more insight. I mean, just like ask them too. Like, how do you decide like what's okay and what's not? Like, what are you weighing? What matters to you? You know, like it doesn't have to be this exact science and so much guesswork. It can be so much more conversational. Here, I like this point about having the physiotherapist as your partner. Level the playing field. You guys are two people working on tackling the same issue. You're not a person treating a thing that another person is dealing with. You're working together. The quote, I only recently have managed to find a physiotherapist who listens and is willing to work with me and help me to plan and manage the condition. So with that, just a much deeper level of involvement in not just what they're doing with your exercise prescription, but like the whole day and what that looks like for them and how different daily activities impact them, how hard or easy it is to do certain things, how it changes with fatigue, like all of that stuff. It just calls for a broader understanding. I think the only thing that worries me when I talk like this is people also have to understand that, like, I am in my own practice and I can do things the way that I want to. And obviously, a lot of these ideas that we're talking about aren't super pragmatic for a lot of people who are in different clinical situations. Like if you're in a rack and crack Chiro center, I mean, good luck with this. Is an EDS patient coming in to see you? Probably not. But I'm just saying, I understand that as I'm saying all this stuff about the level of relationship we should be seeking to develop with the person, that's not going to be reasonable for everybody. So, yeah. Anybody else have any questions, comments, anything? Keep kind of scrolling here. I'll start to wrap it up here too soon. Here talking about, okay, perceived level of like expertise has specialized in hypermobility syndrome. Like, again, you can go a long way by just demonstrating to the person in any way, shape, or form. Like, you don't have to lie about some kind of credential, but just show them that, like, you probably know more than the average person about what they're dealing with. And because you'll all be so well read on it, because that's what you do, you should feel confident in saying that. Again, concerning my body, have helped construct me an exercise program designed specifically to try and combat my worst problems. So, that's what is most limiting for you. When do things seem to subluck most consistently? What are your biggest apprehensions? Tailoring things around that. I mean, right? It's just that whole person-centered idea of rationale for giving exercise. I mean, look at that. Yeah, this is like the whole approach right here. When I'm having problems doing some exercises, he'll either tell me to stop or he'll alter them for me so I can do them, right? And that's what we talked about a little while ago, which was mapping out progressions, regressions thoroughly enough, depending on the person, that if they're having a bad day, they've got options rather than being made to feel like, well, it ain't happening today, Here's a good ode to manual therapy, talking about hands-on. If somebody's really into form or corrective exercise, I think you can leverage that in a situation like this. Sort of a guardrail type thing. So like if you wanna, I'm not big into form or biomechanics, but if you want to be really anal about that and take it and use it contextually to make the person feel more safe, I think you have an opportunity to do that here with, like, whether it's touch cues or verbals. I don't know, like, as much as I usually think of being super hyper vigilant about form being a nocebo, I think if you just do it and set it up the right way, if that's what you want to do, I think you can leverage it. That's all I'm trying to say. So like manipulating context around certain things to make somebody feel more safe or more capable of something. I think that's one good kind of takeaway from this stuff right here. More high praise for physios who know what they're doing. And then here's a bad one. My first physio was diabolical and did no help whatsoever. Yeah, how about that? You don't want to be that one. Yeah. There's one more thing I wanted to hit, but I think we can kind of start closing it down because I'm starting to feel more rambling and scatterbrained the more I'm talking. Yeah. I just got to find this last paper. Any other questions or anything coming up?
Going back to you sending papers to the patient, when is a scenario that you would send a quote unquote bad paper?
Yeah, again, that for me so far, it's just been when I see an opportunity to build some level of relatedness, or at least like to double down on trying to show them that I've heard what they were telling me and like that I took it seriously. And that showed up as like sharing qualitative stuff on misdiagnosis with somebody who told me they'd been misdiagnosed, and like the message in and of itself was negative overall because it was like expressing frustrations with medicine. And like on the surface level, like you would think if you didn't understand this stuff, you would be like, well, I don't want to share that with somebody. It's going to make them think that we're all incompetent. Well, they already think that. So, it's like, this is kind of my whole rationale, honestly, with some of the ugly bits of chiropractic. Like I get criticized all the time on the internet by people saying like, why do you say all of these things that are so critical of your own profession? Like, do you hate your profession? All that kind of stuff. I say, no, obviously not. It's all I talk about. What I'm trying to do is say, hey, yeah, like this shit sucks. Let's not pretend it doesn't. Let's look at look the ugly part of it in the face. Let's be transparent about it and show people that we acknowledge that this is fucked up. Let's not sweep it under the rug and pretend it's not here. And what that's done for me, as far as like, again, from a marketing perspective, that's been huge for me as far as people starting to trust me and reach out because they're like, wow, this guy isn't pretending that everything is great. And he understands our complaints with his line of work, which tells me as the patient, he's not going to do those things, So I think there's value with that. Even if it's a negative message overall, let's acknowledge it and let the people know that we're aware, right? I think that's kind of the main thought process behind when I would share something like that. Okay. So main considerations under the word results right here when they're trying to decide like how to proceed with, I think they talk about things with obviously activity, but also they talk about social stuff too. So like whether they're going to go out with friends or whether they're going to go to some kind of activity, right? So key considerations: keeping pain manageable. Obviously that doesn't have anything to do with abolishing pain, right? Just keeping it within a tolerable level so they can live. Is it worth it? So that touches back on what I mentioned earlier. It's more of a cost benefit type level of decision making. And what I actually thought too is really cool right there that you could do. If you're talking to an EDS patient, you're kind of recognizing that the way they are making decisions and what drives their behavior is this sort of cost to benefit mindset. You could build relatedness right there and say, well, hey, like as a healthcare provider, that's how I make my decisions in care too. So my decisions for what we do with your treatment and your decisions that dictate what you are and are not comfortable with on a daily basis, so they're going to be right in line because we're using the same logic. I thought that was a cool opportunity too, to kind of peel back the curtain for these people and build sort of that level of relatedness there. Unpredictability of pain, I think that's hugely important for us to prepare ourselves for. Oh, damn, I should have said more about this too. Control. That's what I'll close out with. Control. So giving people control over the situation. Obviously, like if you read on pain signs, if you've read on some of the mitigators of that and how beliefs change things, a level of perceived control over any situation really can change, not necessarily always pain intensity itself, but just the way we behave around it and how limiting things become or do not become. So like, how can we leverage that? I actually want to just see what you guys think when I say that. So how can you leverage like giving people control over a situation, or what could you do as the therapist to make them feel like they have more control either over their pain or over how their pain impacts their life? I'm curious if you guys have any ideas just hearing me say that, or if you need more clarification.
Well, to two of your examples, I think telehealth one like helps because once they're done with the call, like it's up to them to progress forward and they can't come into clinic physically. And then the second is what you talked about with progressions and regressions. Like you've given them the ability to control how they alter their environment or the difficulty of the task. So I think both of those are very easy examples.
Yep, absolutely. Another thing I would add with that, but that's a little bit more pragmatic, is like, okay, what type of exercise? Like, what type of specific exercise prescription might give somebody a more contextual feeling of control over a situation? Like, what would you guys think there? Because I know what I do for that kind of scenario all the time, but I'm curious if you guys have other ideas.
I mean, I would probably just say what is most like easily accessible to them is probably going to be the easiest.
Yes. Fuck yeah, that's really good. What do you mean? What do you mean? Like, go more into that. Easily accessible as far as what?
Yeah, I mean, as far as their training history, equipment and space, variety, a green
Yep.
space, the
Yep.
environment outside. Like if it's freezing cold, they're probably not going to be a crazy runner. You know, they're not going to want to
See,
go
that's
run
why
out.
we talk about planning too, right? And being involved with that. Like, that's what I'm kind of saying. That's perfect. That's
Yeah,
awesome.
there's just a level of what they're comfortable with, and I say accessibility just because I feel like I look at like myself and what are things that are probably like on a priority list, like really easily I could do in a heartbeat. And then what are things that are like, ooh, that's going to take a lot of planning and
Yeah.
time. Anyways, you get it.
No, that's great. And that reminds me too. And I was going to say, like, an example I've used. So, one thing we changed, and there's give and take with this too. Like, we switch it up depending on what the person feels like they need. But one person, so we know the role of fatigue and we know how exercise tends to behave around pain. Well, to get to their gym, they would walk, and it was a long walk to the gym, right? So then my suggestion was, well, I'll be honest, like, I love walking. I love that you're going to the gym. I think the two compounding might have more of an impact on you than we're maybe aware of. So for that person, we pivoted to just at-home exercise because it turned out that they preferred it anyway. And on top of that, like, we take walking out of the equation, and the reason they had just been continuing doing that was because they were under the impression that because it's a hypermobility thing and they sublux, they have to use like dumbbells and resistant, like they need to get bulky. And like that's just like the idea they had, which is why they were doing that despite how it was making their pain behave. So yeah, saying like, okay, well, let's kind of that's what I was saying earlier about setting that person up, so things are a little bit more conducive to a better outcome. Manipulate that environment a little bit, take the walking out. They don't have to go as far for the workout, easier access, and it's something they enjoy more. I mean, that's, when you put all those things stacked up, it's a no-brainer. It all seems really common sense. Okay. Potentially a risk. Any other thoughts on what might give somebody a better sense of control over things? One thing that I do a lot is so like isometrics and what their role is gets debated all the time online, and everybody's like, oh, isometric for tendinopathy, whatever, who cares, right? Who cares? Here's the thing with that though that I really like about isometrics. For anybody who has any sort of persistent pain, isometrics, you are in full control over how intense it is, because you're literally just dictating like how hard you're pushing into what you're doing. And if you explain that to the person and say, hey, like, this is like a pressure gauge, and if it's too much for you, like, we're not moving a set amount of weight here, and we're not going for like a set amount of reps necessarily. Let's just have you do this, and you can decide how hard you want to push into it, but you're in full control over that situation. And then like for somebody with EDS, I use that a lot, especially like if we're going with a graded approach, starting in those mid ranges that are a lot more non-threatening. and then using that some kind of good isometric prescription, letting them know, hey, you have full control over how hard you push into this. Bottom line is your muscles are contracting and you're getting work done. We're getting that time under tension. We're getting some level of adaptation. And like, that's the other thing we have to understand too, is with capacity and adaptation, a lot of these people are really deconditioned. So we're going to see positive return on investment, not necessarily super measurable, but they are going to get adaptation, even if it is low level body weight stuff, because a lot of the time there is that level of deconditioning with all the avoidance, right? So leveraging isometrics in that sense as a means of putting control in their hands and letting them know about it, I think is a really good move to do. And then another thing that made me think of, one of the papers talked about, and this was super bias confirming for me, they saw really good outcomes with training people in the end range that they're known to sublux at, right? So obviously you wouldn't do that right away unless you felt like your relationship allowed for it and the person was like, that was going to work for that person. But I mean, you know, based on what we know about pain and how threat perception, especially in persistent conditions, has such a strong role there, taking them into that end range that they know is inherently dangerous to them because their joint has popped out in that range so many times, exposing them to that tolerably and gradually over time in a non-threatening way. The fact that in a study that actually showed additional benefit beyond just general shit, I thought that was super exciting too. Because like that, before I knew this stuff, that was the kind of working model that I was going under, just based on extrapolating data from other areas and other conditions. I was like, okay, well, I think part of this is going to have to be expose them to that range of motion that danger is highest, but do it in a controlled, tolerable, safe way. So leveraging that too. I think that's one that for me so far I've seen takes a considerable amount of thin slicing and slower workup. I wouldn't start there, obviously. Yeah. Okay. Kind of final thought there. Wow, it took me this long to roll. Exerting control. See here, they're talking about distance. If it's something, say, around the corner or something short where I know I can leave and go home and relieve the pain or something, then I do it. So for them, like, they're associating pain relief with whatever it is they're doing at home, whether it's bed rest or ice or whatever somebody does, right? Literally, like, that mattered to them as far as their willingness to do the thing and dictate that behavior. The fact that they didn't have to go far because they had that crutch to fall back on if they had to, that made them more willing to do it, right? So it's like we kept talking about, thinking in every situation and having a really good understanding of all the context around different aspects of their daily life. How can you leverage all of that and set that up to make just everything throughout the day more conducive to win, 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 right? Just manipulating all of those variables and looking beyond the simplicity of exercise prescription, time under tension, reps, sets, load, all that bullshit, right? I think it's a good, really comprehensive way to look at things. Man, I've said a lot of words. You guys have any other thoughts? Otherwise, I'm probably going to be done talking. Any other questions about just EDS in general? Things that you guys feel like I totally missed or misunderstood or am leaving out? I'm sure there is. There was a lot I wanted to talk about, and I know I didn't get to all of it because I can't remember it. So
I thought that was
Cool.
great, man. It's a
thanks.
yeah. Could you email those other papers you sent over? Because those are great.
Yeah, it's all super good stuff. Don't read the Nature primer. It's not worth your time. It's way too long, and a lot of it's basic sciences that don't help. So fuck that one. But I'll give you the rest.
Perfect. Thanks, man.
All right. Cool.
Sweet.
Hopefully that was helpful in some way, shape, or form. Every time I talk to people, especially students, I always feel like I say a lot of things, and then at the end, I'm like, Wow, I really didn't actually say anything. That was wild. It's like a total blackout. That was fun.
No, that was great. I got a
All
lot
right.
out of it. And I don't know if our class or my school even talked about EDS, but
That sucks.
yeah, I don't think we've talked about it. If we
Well, now
did, I
you can
blacked
lead
out.
it.
Pardon?
Now you can lead the talk on EDS.
Yeah, for sure.
Go bring with that sweet radio voice of yours. Go bring it up. They would love to hear from you. So smooth and melodic. Do you sing?
No, I'm a trash singer, but my sister does.
You should learn from her.
I should. Yeah, for sure. She makes fun of me when I try. So
All right, guys. Well, if anybody ever wants to talk about anything at all, hit me up because I like talking about this stuff. Just prepare yourself because sometimes it takes me a long time to speak coherently. So
sweet.
part of the
Well, thanks, man, for leading it and for all of your input. And thank you, everyone else, for joining the party. Next week, it's going to be Andy Chen talking about, I think,
deal.
plyos.
Oh, Andy's the man. Can I come back?
Oh, fuck yeah, dude. I'll just put you in the calendar invite. And then after that, it's going to be Dr. Thomas, I think is his name. He wrote like Zero Pain is Not the Goal. It's going to be a legit discussion. So get stoked. Okay. I'm ending this. Thank you all again. Enjoy your long 3-day weekend.
Toodaloo, motherfucker.